very excited to be doing this tonight. Digital dentures are something that I'm really passionate about. I am compensated by Dentsply Sirona and also Avident, and I began making digital dentures with Avident, and I now use digital Dentsply Sirona materials that are engineered by Avident. However, I've really tried to make my presentation relevant for any manufacturer of digital dentures currently and relevant for lab technicians, dentists, denturists, basically everyone. So first of all, what is so great and what do I love about dentures? And what is so difficult about making dentures? I think that giving results to patients like this, where they're happy, they can smile, they can function, they feel, complete again, is one of the greatest benefits of dentures. However, when you really think about it, making dentures is really hard to do. In fixed prosthodontics, we can move incisal edge positions by 1, 2, maybe 3 millimeters. But with dentures, you have to be really skilled at getting the teeth in the right place. And with digital dentures, you still need to have the same skills to be able to put the teeth in the right place. So that's one of the concepts that really have not changed and why dentures are so fulfilling but yet so difficult sometimes. When I graduated from dental school, I was like most dental school graduates. I felt like I knew nothing about it and I did not love dentures at all. That did change though because of this instructor here. Dr. Ernest Svensson was one of my prosthodontics directors, and he would for some reason assign me every patient who had a difficult ridge, who was difficult to work with. He thought for whatever reason that I was good at it. I remember he would give me a 90-year-old woman with absolutely no ridge, whose chief complaint was, I want to eat raw celery and carrots with my new dentures. And I would go to Dr. Svensson and say, Dr. Svensson, I cannot help her. This is what she wants. It's impossible. And he would say, oh, come on, Val. Can't you just sharpen up her teeth a little? Can't you do something? And he would make me treat these patients that I thought were impossible to treat. And so I developed a love for making dentures. And my co-residents started calling me the denture queen because I was getting assigned so many dentures from Dr. Svensson. And since then, I started to just run with the nickname. I created this cute little logo for my Instagram, and currently on my Instagram, you can see crazy things all about dentures. So border molding with my gum, everything. I like to post and share as much information as I have. But let me get back to the story of where it started. When I graduated from my residency in 2009, I had been processing and doing all of the lab work to make dentures. And I was really excited to not have to do the lab work ever again. When I first began using labs, I would be frustrated by some of the problems that I perceived were wrong with the dentures. They would constantly cut off the retromolar pads. There would be uneven palettes. Basically, I felt like I didn't have control with making the actual product. I started collecting my bag of dentures here on the wall of dentures that I had made that for some reason I had to remake. The patient wasn't happy, I wasn't happy, they weren't right. And having all of these dentures hanging there was this constant reminder that something was not right with my process. That was my motivation to get started with. I wanted to become better at making dentures for patients. So in 2012, I started working and making dentures in my practice. I had one technician for 2012 and 13, and then I hired another technician in 2014 and 15. And I have to tell you that it was really tough at first. We really struggled. And even though I'd made lots of dentures in my residency, there were some dentures we made that really were awful. And it was a learning process. But by about 2014, 15, our systems were better and we were getting better results, and I was happier because there was better control. But there were still limits because conventionally produced dentures, there are things that aren't exactly perfect. For example, here, when you cut off teeth for an immediate denture, it's very difficult to reference back to the original tooth position. The try-ins don't necessarily fit like the final will. I have never been a fan of moving teeth in wax chairside. I've done it, but I don't love it. And I always felt like even if I had the ability to move teeth chairside, I really wasn't happy with finalizing that unless it had been returned to the lab. And of course, teeth shift, borders changed, and most importantly, once you've processed a conventionally made denture, you're basically done. So even though I had all of these problems, I still pressed on. And one of the things I started doing in 2013 was I would hold a free denture event every year in April for National Prosthodontics Awareness Week. And I would invite technicians and prosthodontists, students to come in and help me make anywhere from 6 to 10 sets of dentures for patients in my community for free. But it was during this event that I had what I would call patient zero. And this is when the entire epidemic of digital dentures started in my practice. So I had just delivered a maxillary denture mandibular hybrid. And within the next week, the patient had called and said that not only had 2 of the teeth fallen off of her hybrid, which happens, but also 2 teeth on her maxillary denture had fallen off. And not only that, she was having a burning sensation in her mouth whenever she wore the dentures. And I was just besides myself, furious. Of course, I blamed the lab that had been processing. They, of course, blamed me. And yes, it was my fault slightly and their fault slightly, I would say. But I was just fed up with the whole process of dentures. And one of the Ohio State residents who was at my Prosthodontics Awareness Week event helping, he said, well, why don't you use Avident digital dentures? And I said, okay, well, surely that's not good. Surely that's some sort of a gimmick. And he said that they had been using it to retread hybrids, and that when you do that, the teeth in the acrylic are monolithic, and there's a lot of great advantages to it. So I decided to look into it. But there was one part that was missing. You know, being a trained prosthodontist meant that I was trained that face bows are very important, occlusion, very important, doing lots of chairside try-ins, very important. And that had started to dissolve in my first few years of practice. And part of that was because of a speaker I listened to in 2009, Gunnar Carlson. Gunnar Carlson had laid out in a great presentation his opinion on some of the famous dogmas in removable prosthodontics. He made an excellent case that most of the factors critical to denture success are not actually factors that we think are important. Psychological factors, in his opinion, and he argued it very eloquently, are the most important in denture success. That he felt like arbitrary articulators, no face bow, would be sufficient. He felt like the occlusal scheme, whether it's even canine guidance or full balance, was not important to the result of the denture. And so he also made a case that actually the impression material itself or the means of the impression was not that important when you're looking at clinical success. And he highlighted the importance that implants do not solve all problems, so we cannot get away from the fact that dentures, full tissue supported dentures, are still important in prosthodontics. So these facts had been brewing in my mind. And so when I looked into getting digital dentures, I was like, well, you can't do a face bow. You can't set the articulator. How is this even going to work? And so by having an idea that maybe these things weren't as important, and if I had a better tool to help people make dentures better and to be better psychologically, That might be the most important key to denture success. So I was drawn to the idea of the potential to decrease the clinical and laboratory time with digital dentures. I like the idea that you could mill or make teeth monolithic so that you have total freedom in design. The ability to evaluate the fit of the denture at the try-in is impressive. I liked the idea that you could easily alter, remake, duplicate endlessly, change the design precisely with digital, and that the quality was uniform and consistent. And the last part is the digital preview. I really liked the idea that I could see exactly what my denture was going to look like before it was ever made, and I knew that I would pretty much get exactly what I saw. So this is a paper that I put in about the current manufacturing techniques and ways to make computer CAD dentures. All of the literature on digital dentures is almost out of date, in my opinion. So it is difficult to really study the literature of digital dentures because much of it is not relevant to the way that much of it is done today. But you can see here that I would say the biggest methods of making digital dentures are by subtractive means, milling. Although there are ways to make digital dentures by additive means or 3D printing. So this begins the slightly boring part of my presentation with just words because I have to go through all of the different ways to get through the process. So the first step is you have to generate the actual denture records or the quote impression of the patient. Initially, makers of digital dentures were focused on conventional impressions with a Gothic arch type of device to record centric and also the maxillomandibular relations. I have to admit that I've not used a Gothic arch type of device since my residency, and I feel like they are difficult for me and possibly other clinicians to use, although if you feel comfortable using a Gothic arch device, that's wonderful. The other means is to use conventional impressions and also wax rims, or conventional impressions using a reference denture, conventional impressions to generate casts. There are means coming up to use intraoral scanning directly, or I've heard of CT scanning. So once you have your impression of the denture, how do you make that into a computer file or a 3D STL file? Most digital dentures are made by using a laboratory scanner to scan the impressions, the wax rims, a setup, or the Gothic arch type device. There is the potential of using possibly an intraoral scanner to also scan the impressions or casts. And I know it's also possible to scan impressions and casts with a CT. Next step is you need to put your digital 3D files into a denture settings software. There is proprietary denture-specific software, and that would be the Avident software. And there's also, and possibly others, there's also general dental CAD software like ExoCAD and 3Shape, which have denture modules. Next, there are many different ways to generate a final finished product that is digital. You can 3D print teeth and 3D print bases and bond them together. You can mill out teeth and mill bases and bond them together. Then there is a way to mill a custom-made puck that contains different layers of tooth material and base material and mill the whole puck, generating a monolithic denture. And then there are also means to have manufactured teeth. The traditional teeth that most doctors are used to using now can be bonded to a milled or printed base. Now, a lot of people ask, what are these materials made of? Milled bases and teeth are usually made of the same acrylics that conventional dentures are made of. They're made of methyl methacrylate, which means they have similar properties to a conventional denture. A methyl methacrylate milled denture base can be relined, it can be repaired, and the only difference is that when it's manufactured, it's pressed into a puck at greater pressure than conventionally processed. Some people ask what brands of teeth are available with digital dentures, and that depends on what software you're using. So some softwares you have to pick the appropriate tooth library. Evidence software has their own choices for teeth, or when you're milling the actual teeth, you can start from a generic tooth and mill out a custom tooth. Next are what Tri-En products are available. And I have split Tri-Ens into two sections, static and dynamic, because most Tri-Ens used for digital dentures are what I would call static. You cannot move the teeth. It is not the same as having manufactured teeth set in wax and moving them in order to generate your Tri-En. The Tri-Ens with digital dentures are actually just a milled solid piece of acrylic. You can also 3D print Tri-Ens, and that's another type of static Tri-En. And also under static are manufactured teeth set in a milled base. When you have a milled base that has tooth pockets milled into it, and then you place the manufactured teeth into it, and you take that to the mouth to try it in, you cannot really move those teeth around. They are set in a pocket. Dynamic Tri-Ens, there's really two ways that I know of to do that. And one is called the Wagner Tri-En, which is a novel type of Tri-En where you have milled teeth set in a wax-like material that you can move around to establish tooth position. But it is also possible that you could generate a digital denture by setting manufactured teeth in wax on a milled base plate. So that would be a movable type of Tri-En. Additional products. It is incredibly easy to generate duplicate dentures, surgical guides, bone reduction guides, radiographic guides. Digital dentures have the ability for you to be able to digitally reduce the teeth and reduce undercuts for immediate dentures. You can create hybrids and overdentures easily digitally. You can have metal frameworks incorporated into dentures, obturators, and partials. As a brief note about partial dentures, I do know that there are means to design frameworks all digitally and then proceed from there. But the way that I'm familiar with for making partial dentures is I scan the mouth and then 3D print a cast and then conventionally process partials from there. However, there are ways that are coming about to make partial dentures directly digitally as well. Additional finishing steps. So stippling can be added post-processing as well as custom gingival colors. One of the really neat things about digital dentures is you can take the palatal surface of your patient and lift it to create a custom palatal surface of the digital denture. So the palatal rugae are the same as the patient's palatal rugae. Do you have to place a post-palatal seal with a digital denture? Yes or no? That really depends on your preference. The traditional reason for the post-palatal seal in denture prosthetics is to compensate for the shrinkage of the acrylic during processing. However, I have experimented with placing post-palatal seals and not, and have done a lot of dentures both ways, and I have settled on my favorite, which is I place a post-palatal seal, even though it's a digital denture. But that is free for people to experiment with, and I am not aware of any research that has been done on whether or not it's necessary or not. And also tap milling. tap milling refers to when you have a finished digital denture and you would like to take the digital denture and accommodate for the opposing teeth, you can place it on another mill and have the mill carve out the opposing dentition. And we'll get into some of these things later on. So, knowing all of the options for digital dentures, let's get back to my story. I threw out all of my conventional denture processing equipment and created my new removable lab, much cleaner, with my lab scanner, computers to do the setups, printer, and all of my technology. So when I was first asked to talk about digital dentures, I really wanted to see if I had any actual data about did digital dentures make any impact in my practice. So I pulled data from my two practices. I have a prosthodontics practice and a general practice in separate locations. And so this picture you can see myself, my associate, my staff. And I pulled the data from about the practice as a whole for 4 years. The first thing I wanted to know was, since I started using digital dentures, did I make more dentures? And the answer is absolutely yes. From 2013 to 16, we made twice as many dentures. Now, anytime you start doing a lot of something, you're naturally going to get better at it. So I also wanted to see, were any of the steps, were any of the promises of digital dentures kept? Were there reduced chair time, reduced clinical time? The first thing I looked at were the number of try-ins. With digital dentures, you have to work from an accelerated try-in workflow, and I noticed right away that my try-ins dropped from between 2 to 3 per denture down to less than 1 per denture. You might be saying, how do you do less than 1? Well, first of all, I do include immediate dentures in my total number of dentures, and those don't have a try-in. And I also do make some dentures without a single try-in. So if you look at my current data of 0.4 try-ins per denture, rather than 1.8, which, let me go back 1 second. Oh, there it is. Okay. In order to properly compare these numbers, I wanted to know, when was I doing the best at dentures? And that, I decided, was 2014. I mean, prior to doing digital. So before I went digital, that was 2014. I had my experienced lab technician. I had everything right in my practice. I felt like we were doing a great job. And so when I looked at these numbers, I wanted to compare 2014 to 2016. And so when you put it all together, doing 0.4 try-ins rather than 1.8 saved an average of 170 hours in 2016, which to me was significant. Now, the next number I looked at was the number of adjustments. And before I pulled this data, I would have told you that I didn't really feel like digital dentures made much of a difference in terms of the fit, post-operative adjustment visits at all. But when I pulled them, I noticed that if you look at 2014, when I thought I was really doing really well, and compared it to 2016, we reduced the number of adjustments from 4.8 to 2.7. And that, when you have a practice making 180 dentures, resulted in 246 hours of saved chair time. So the first thing I wanted to investigate after that was if these dentures did result in much fewer adjustments, which, first of all, anytime you do something more, you're going to get better at it. So I wanted to know, was this just me, or was there an actual difference in digital dentures? So this study looked at, do the dentures produced digitally fit to the tissue surface the same as conventional? And the answer is yes, they do. The next study I looked at evaluated, do they possibly fit better to the tissues? And the answer is yes. And here's a nice little illustration of how well a digitally produced denture fits because there's no acrylic shrinkage. Now, one criticism I wanted to bring up here is, does this really matter? If you remember the work of Gunnar Carlson, he made the great case that a denture made from a alginate impression was indistinguishable from a denture made with border molded conventional techniques. So please keep that in mind when we're just having these discussions about the fit of and the process of digital dentures, that it's nice to know that yes, they fit well and they have a great fit compared to other means, but it isn't the most important part of all of this. The most important part is the clinical success. And this study looked at, does the digital denture process work clinically? And they looked at a pre-doc setting, making digital dentures in the 2-appointment method. So to me, I think that's kind of difficult to have pre-docs making dentures in 2 appointments. And what they found was that the digital denture process was a great process for even pre-docs and even with the accelerated workflow. And lastly, are the clinical outcomes positive? And yes, they found that there was reduced clinical time, improved fit, and the advantage of being able to digitally archive your denture designs was one of the main advantages. There was another study I did not include that did discuss one of the disadvantages of digital dentures is that it does take a significantly greater amount of clinician lab communication. And I would say that that is true. There are more emails and communications going back and forth. So even though everything I've presented so far is very good, there are definitely some struggles with digital dentures. So overall, you have multiple different ways to create digital dentures. There is what I call a conventional digital workflow. There's immediate, there's the reference denture, and then there's the Wagner technique. I can't go into the specifics of exactly how you do each of these techniques, but I have included in your handouts for today, which are on the website, all of my clinical checklists and appointment steps so that you do have them. So the next thing I wanted to talk to you about are the 3 major differences with the clinical aspects of digital dentures. And originally I had 6 things here, and I really had to try to really squeeze it down into the 3 most important differences with digital dentures. So the first one is that you can easily combine and visualize all of the layers of the denture design. And what I mean by layers are the different references when you're looking at your design. So first of all, this is an alignment of 2 different scans of the same denture. And that is kind of nice to just look at it for fun. But where that comes into play is that it is possible using digital technology to combine 2 different impressions of the same patient into a usable digital file. And what I mean is you take one type of record, a completely different type of record, you tell the computer which points align, and you create an alignment. Now what that does for you is you can now add additional information to your digital record. So for example, if you have an implant master cast, you can merge the tooth setup position from a completely different record. And now you have all of the information from that secondary record combined with the first. It allows you to get the information back to the virtual design. And this is very different from a non-digital workflow. In a non-digital workflow, you have to you have to start with a master cast, and then you have to make records that fit only that master cast. And those records will not fit on a different type of record made from a different cast. And so what digital alignment means is you can take two different scans of the same object and merge them. And that is a completely different approach than the analog method of doing this. So the non-digital workflow normally starts with preliminary impressions so that you can generate custom trays. Then you make your final impressions. Then you make a wax rim or a record base. And then you take your records for occlusion, lip support, midline, etc. Well, with the digital workflow, you can make preliminary impressions and then have lab-made custom trays and records at the same time. And then your first clinical step is to make the final impressions and the records at once in one visit. So this is how they would do it. They would take your final border molded impression, and then they take your secondary record, whether it's a Gothic arch type of tracing device, whether it's a wax rim that you've simply relined and made all of your marks on, and they can take those two completely different records and merge them digitally. So many doctors who are new to digital dentures, I suggest this is the easiest way to start, because you're using the same clinical steps and skills that you've always done. It's just that you've combined it into one visit. You're going to make custom border molded impressions in a separate product, and then you take a set of wax rims and simply add a little bit of a wash material and make all of your references and notes on those wax rims and send both of those records for digital alignment. And now you have the records that you need. You're going to have notes for your vertical dimension, you're going to have your occlusal relationship, midline, canine line, all of that, and you've done it all in one visit. Now, some doctors prefer to make their custom tray the same as the wax rim in one piece, and that is possible as well. But the simplest way to do it is to have separate custom trays and separate wax rims, make an impression in both, and merge them later. Now, my favorite digital workflow is the reference denture workflow. And I love it because it's a classic technique. It's been described for a long time, and it allows us to layer in a lot more information than I think is conveyed in a wax rim. I've never loved working with wax rims, and I don't ever want to work with them again. So in the reference denture workflow, you would duplicate your dentures and then make your final impressions and records in one visit. With it, this is an example of how I would take a patient's existing denture and use it as an impression tray. You can use any impression material that you like. Some doctors prefer a functional impression technique where they're using a denture reline material. You do not need to have a special material to make a digital denture. Almost every material can be scanned by a laboratory scanner of some way. So why do I love the reference denture technique? Because most of my patients have been wearing their dentures for about 10 years. And they are very comfortable with the way their dentures basically look and feel and function. They just want a little bit of an extra stability and retention, and they probably want their teeth to show a little bit more, and they don't want worn teeth. So I really like to be able to extract all of the valuable information from these dentures into my design for the finals. So I want to scan their dentures with, of course, a new tissue surface and a new bite record. And I love to actually use the patient's own dentures. The biggest suggestion that I have when you're going to use the reference denture technique is you have to avoid having the two dentures contact in the area I don't know if you can see my mouse here, but right between the maxillary and the mandibular record, you cannot have any contact there. We call it heel contact. And if you have heel contact, your bite record is not going to be correct. So how can you actually use the patient's dentures to make all of these records? That would be by the use of intraoral scanners. So I'm not the first person to start scanning denture records with intraoral scanners, but it was a really exciting idea when I heard of it, and I wanted to try to figure out the best way to scan the actual dentures with an intraoral scanner. I use the Trios, and I've worked out exactly a great technique to do this, which I have on Instagram and Facebook. But essentially, I took and scanned the tissue surface of the maxillary denture, including the teeth, the tissue surface of the mandibular, including the teeth, and then I scanned them in occlusion. And from that, you have all of the information you need, including the entire history of that patient's denture. They will be able to tell you, I love the way my teeth look, or I want my teeth longer, I want my teeth shorter. So I have done my own research on, is the intraoral scanner able to get all of these records? Is it accurate? And I have found that in general, there's about a 0.2 millimeter difference between a laboratory scanner and the intraoral scanner. But moving on, one of the amazing advantages of digital is that when you're setting teeth, you have the ability to click back and forth between the current tooth position and the new tooth position. So here, when you have an immediate denture, you can see that we can see the exact proposed changes we want, as well as the position of the patient's current teeth. So with the scans of the patient's current teeth and photographs, we're able to do a lot of really neat things with moving the teeth and constantly referencing all of these great anatomical references, where their teeth are, where we'd like their new teeth to be. And having all of those references is, to me, the most wonderful part of it. However, the most important difference with digital dentures is the try-in process. It is completely different. If you remember, there is a static try-in, which is mostly used, and a dynamic. I'm going to talk about the static try-in process because that's what I've done, and that's what most manufacturers will give you. They'll give you a denture that you cannot move the teeth. One of the greatest benefits of having a try-in that's digitally produced is that the try-in itself will fit exactly like your final product will. So here I have a photograph of a denture where clearly we did not capture adequate borders, and I peeled away the reline impression made with this try-in denture. So when you have a try-in that does not fit, you are able to correct it. These static try-ins are available in different shades usually. The first step with using one is you need to treat it as if you're seating a final denture. You need to use pip paste and adjust it. You have to mark it, adjust, reduce, add composite, use it to make a new bite record, and you can send it home with the patients if you want. The biggest error that doctors make with using a static try-in is that they evaluate the try-in before they add impression material if necessary. So if you need to add impression material, if your try-in does not fit, you need to make all of your changes to the teeth before you add the impression material and then make detailed notes. I use a checklist to make sure that I am evaluating every single aspect of these try-ins. So the biggest controversy with digital denture try-ins is that you may no longer need to go to a final aesthetic try-in. First of all, when you order an exact 2 millimeter midline shift from your try-in to your final, you will get exactly a 2 millimeter midline shift. So that's a great benefit of the digital process. The greatest problem with the digital process is that the try-ins themselves are relatively costly. And if you generate 3 try-ins for a denture patient, you will never be able to afford to make digital dentures. At the most, I do 0 or 1 try-in for each patient, and that is a huge difference. Normally, we are used to working with this, where you make your denture try-in until it's perfect, and then the patient signs it and approves it, and you make your final denture. Now, first of all, that never worked great for me. It does not guarantee that the patient is not going to return and say that they're unhappy with their denture. So I made the leap of forgetting that form. And when I had a try-in that was pretty much right, and it just needed a 2mm midline shift, I would not order another try-in and go straight to the final. Now, there's a risk when you are working with 0 or 1 try-ins that the changes, the specific changes you make are not going to be, it's not going to be exactly right. You may have to remake your final dentures when you work with an accelerated try-in like this. But overall, I felt like it worked very well. And the reason I think it worked is because of an idea called the paradox of choice. Normally, when I make a try-in, I send my patient into the restroom. This was conventionally, and I would say, go in there and really look at your denture and tell me exactly what you want me to change. These teeth are in wax. I can change all of it. Just tell me exactly how you want it. And they would come back and they would say, I don't know, I think it's okay. And I don't have time to talk about the paradox of choice, but this psychologist gives a great TED Talk about why when we give people an infinite choice or choices that are hundreds of choices, they end up paralyzed and generally dissatisfied with the choices they make. So instead, when I make a digital try-in, I sit down with my patient and I first ask them, does it fit? Does it feel good? If yes, the next step is, do you like the shade? Would you like them lighter or darker? Do you like the size of the teeth? Do you want them bigger or smaller? Do you like the relative position? Do you want them up, down, left, or right? So essentially, I've given them about 6 to 8 choices. And when we go through those choices, we end up with, yeah, I like these teeth. I just want them slightly bigger. And that is how I proceed with making the final dentures. I do not do a final aesthetic try-in. And I think it works out better for me and my patients, although it's quite a change. So I've likened this to making dentures is like a game. And I don't want you to think that the game is between me as a doctor against my patient. It's in fact a 2-player, multiple player game that we are both trying to achieve the same goals. So you start the game, you have your personality and assets on one side, and you have your patient and what they bring to the game. And then you select your level. What type of denture are you going to go through? What kind of strategy are you going to use? Are you going to go from step 1 and you're going to go through all of the conventional denture steps? Or are you going to go accelerated? Are you going to do 1 try-in or 0 try-ins? For each appointment in this game, the longer you spend, then that is a negative for you. It's also a negative for your patient. The more products you have to order is more cost to you and more time and cost to your patient. And the more appointments you have, it's more frustrating for everyone as a whole. There is an element of risk to playing the denture game. If you see your denture at try-in and you think, I just need to change the midline by 1.5, and I think that is going to be perfect, I'm going to go ahead and order the final. There's a risk that when you do that, you might not get it right. You might have to order a remake. However, what is the worst case that could happen if you make a final denture and it's not exactly right? All you have to do is use a life and order another one. You see, with digital dentures, if your final denture isn't exactly right, it is as easy as ordering another try-in to make another denture. With conventional, if you do not get your denture right, you have to essentially start over at step one, causing a lot of problems for your patients, for yourself. You're frustrated, and you don't get a perfect denture. So because digital dentures are so easy to generate again and again and make precise changes, I have made the move to not doing a final try-in and taking that risk that the changes I'm prescribing from my try-in will possibly require a remake. So I pulled my personal statistics. How many times do I have to remake dentures because of errors over time? And you can see here that out of 481 denture orders in the past 2 years, there have been about 25 remakes due to errors. So if you remember, I did significantly reduce the number of try-ins in my practice, but there were remakes because I was significantly reducing try-ins. Now, is that equivalent? Did I win? Did we lose? It's a mathematical issue. When I talk to people about, do I need another try-in? I tell them, always start with making extra try-ins. And when you get to the point where you no longer are making changes from your try-ins, now you can confidently move forward with not requesting additional try-ins. And now, just to clarify, not all of these 481 orders are final dentures. This also includes try-ins and other products. So lastly, after 2 years of making digital dentures, there are some significant technological advantages that I did not even realize were there when I started. First of all, this is an example of a monolithic denture with the traditional IPN Lucitone resin IPN teeth, where these teeth are part of the denture base. They act totally differently than bonded teeth put in a milled base, and the advantages are incredible. This is an animation. The digital articulator. A lot of people have questions about, can I change articulator settings? How does the digital articulator work? And it really comes down to, once you get the teeth in position, you have the computer go through the digital articulation process where it refines and puts everything together into a fantastic occlusion. The materials. Again, this is a hybrid with the conventional resins we're used to, with the milled base material, all monolithic and all a great product to use when you don't have vertical space, when you need to have something that's not going to break, when there's a lot of heavy forces. And people ask me, do these products look ugly? Do the teeth look bad? And I would say, no, they look really nice. This is the ultimate test for a monolithic milled digital denture. It is a cell phone photograph of a denture, and these are actually not manufactured teeth that were bonded to this denture. It's all one unit. This comes back to the palatal surface. If you can see here, the palate of this denture is not smooth and perfect. It is lifted from the patient's palate, as well as, if you can see, there's little tiny tooth marks. And that is from the process called tap milling, where we have the opposing teeth are actually milled in rather than spending time grinding it in. I think that's really kind of neat. This is the process for changing the molds by just clicking rather than having to switch out molds. And duplicating your dentures. First of all, when you order a duplicated digital denture, it is going to be, if you have already ordered that same denture, you can duplicate it nearly perfectly. the appropriate time to order a duplicate, I recommend not ordering it when you make your final order, but waiting before the patient receives the denture, you've made sure that it's going to work, that they like it, and then order the duplicate after that. A lot of doctors ask me, if the patient has a denture that they already love, can I duplicate that? That is not true. You cannot take a patient's existing denture unless it was already digitally produced and duplicate it precisely. I tell people you can get to 90% by using a digital process, but you cannot 100% duplicate a denture unless it was already digitally made. Then you can. So, in order to select a digital product, you have to, first of all, think about the demands of your patient. Using monolithic or milled teeth is wonderful for a lot of cases, but the monolithic and milled teeth do not have quite the same aesthetics as a manufactured denture tooth. So for that reason, I recommend, and most people, most clinicians and labs want to start with manufactured teeth bonded to a milled or printed base. There are some cases where you would not want to do that. Very demanding patients who will need multiple try-ins, you cannot generate endless numbers of static try-ins. You might want to select simply a milled base plate and set manufactured teeth in wax on that base plate and then digitize it later. So we know that machines can do this, but the humans are what usually get in the way. So the last part here is I have created checklists in order to help control the human aspect of it, because the humans are the glitches in the digital denture process. For example, it is difficult to really truly see what a denture is going to look like on a computer screen until you get it. There are a lot of errors that humans make because we're not doing a final try-in. If you do not specify the correct shade, you will get a denture with the incorrect shade. So there's a lot of room for problems that I have worked with in trying to make sure that we have a great checklist for each appointment. Humans are naturally drawn to look at one or two details. So when you examine a digital denture try-in in your patient and you notice that the midline is off, oftentimes you will forget to look at the lip support. You will forget to check the vertical. So you have to be disciplined in going through a checklist to find all of these things, because humans tend to look at one thing. With a conventional try-in, you can keep trying that denture in until you get it right. But with digital, remember, you're trying to accelerate it and get to a final product sooner. So I do checklist everything. I teach checklists for everything that I do. And another critical area for the checklist is when you're looking at a digital preview. So many times I look at a digital preview and I think, oh, it's perfect, it looks awesome, I'm good to go. And then I notice my little checklist annoyingly sitting over there behind my computer. And it says, wait, I have to stop and I have to measure this and I have to check that. And every time I go back to my design and I go through my list of things I'm looking at, I find something I want to change. And it has saved me many times, because again, the human in you wants to just look at one thing and say, oh yeah, looks good, I'm gonna move on. And that's not how it's going to work well with digital. So I know what you're thinking, that if I have a checklist for everything, I must be really obsessive compulsive. I mean, I'm a prosthodontist, it's crazy. But I wanted to show you the truth. That was my lab that I showed before. This is the truth of how it looks on a daily basis. I am so wrapped up in my own head most of the time that I need a checklist to look at all of these things and to get it right every time. So it's not me being extra obsessive. It's just a means to help a very disorganized brain get through something that has to be precise every single time. And lastly, if you remember my bag of reject dentures here,
Of course, I wanted to reduce that number, but my number did grow. There are always going to be failures. If your patient does not like your denture, of course you're going to remake it. You're going to make them happy. You have to try, you have to accept that you will fail at some things in order to get better. And so overall, I just want to encourage everybody to work at it, dive in and try to really help these patients who really, really need you. And lastly, what does digital dentures mean for me? It is something, instead of it being a better way to make dentures, I see it as just a better tool so that I can communicate with my patients when they are sitting there at their try-in and they tell me that they would like their teeth a little bit smaller. Instead of in my head saying, oh no, I have to order new teeth and reset these and oh my gosh, I'm gonna have to pay for another cart of teeth, I think, yes, of course, let me make these a little smaller for you. And I love the fact that I have the best tool to be able to help people with making their dentures, and I can do everything that they want, and I have the confidence to be able to make these dentures, and I know that it's going to be excellent for them, and if it isn't, I know I can fix it. Okay, so do I have a lot of debonds with bonded denture teeth? And I do not. However, I stopped using bonded denture teeth about 1.5 years into the process because I love the monolithic products, and so because I've not had a monolithic tooth ever debond because it just can't. So I have not had that particular problem, and I am not sure if other labs have had that problem. What do you use to bond the teeth to the base plate? That would be determined by the manufacturer. So I know that Avident has a specific product that they use to bond it, and other systems use other products, and that would be just based on whatever the manufacturer says. The price difference between digital dentures and conventionally processed. Absolutely, there is a price difference. The digital dentures, I would say in general, are right now more costly than conventionally processed. And that's because it is time intensive in order to design all of the setup as well as the festooning. So when you have a try-in, it is more costly than having a conventional wax base with digital teeth on it. The next one is, do you mill or print your dentures in-house or send it to Avident? I send all of my cases and they are milled, and I do not print anything right now, but it is certainly possible to print try-ins, so it can be done. So next is, can you change the occlusal schemes? And I think what you're asking is, can you change whether the teeth are monoplane, 0 degree, if they're lingualized occlusion, 20 degree, and yes, as far as I know with the software I use, you can specify if you would like monoplane, 0 degree, lingualized, if you want full anatomic, semi-anatomic. So the next question is, I love CAD CAM crowns and use them all the time. Do you see digital dentures coming to the market the same way as the crowns? I do think so. I don't think it's something that you will be producing in your office anytime soon, but manufacturing in general, there's a large shift from manufacturing occurring, in a lab versus in a manufacturing, and there's a lot of change happening with digital dentures, and I don't think it's necessarily a bad thing. It's just a more centralized way of making dentures digitally, and I personally think that the advantages of digital dentures are great, and I can also see the cost coming down soon, so that will be a benefit as well. Form 2 printer. Do I use that printer in the process at all? And I do not use my Form 2 printer for this. However, there are ways you could use it. So I know that some doctors would like to print reference dentures, or you can scan a patient's own denture and then print it. And that way you have a really nice reference denture to use with the digital process. You could do that. Oh, okay. And now I have a question more about the Staub system, which is a mathematical formula to establish a digital map of the upper and lower arch. The measurements come from fixed points such as the incisive papilla, hamular notch, and retromolar pad. I think what you're referencing is that is all incorporated in the Wagner Try-In. So with the Wagner Try-In, you simply submit to the lab your final maxillary and mandibular impressions. You do not submit the interocclusal records, nothing else, no wax rim. And that is convenient and simple for a lot of doctors to do. From those maxillary mandibular impressions, the lab takes all of the known anatomical landmarks from the incisive papilla, hamular notches, etc., and is able to digitally articulate those maxillary mandibular casts in a preliminary articulation, and then they set teeth in a wax type material based on that, so that you then can have a preliminary tooth setup that is based on anatomical references. So if that's a system that you like and are using, then and you find it helpful, I would suggest trying the Wagner Try-In because it does incorporate a lot of those things. The next question is, how is the bite confirmed if you are using bonded teeth? Is the denture rescanned and then checked, or do they just assume the bonding and placement is accurate? I am not sure if you're asking one of two situations. So the first situation is, let's say you have tried in a bonded tooth setup and you feel like the bite is correct. What you would do is send that back, and I believe that they do rescan it, and then when they bond the teeth in, they scan it again and then color map it to ensure with quality control that it matches the original position. So that's what I think you are talking about there. Next, can you print try-ins to save cost? I do think you can, and that depends on which manufacturer you're using. So some manufacturers might charge you a fee for the design file, and then you can print it yourself. And other manufacturers, I'm not sure how they do that. Do I see myself owning an in-house milling and printing machine in the future? And I would say no, because I have very little interest in maintaining milling machines myself, and I really like the idea of centralized milling occurring in another location. It just would be a lot of staff training and maintenance and upkeep, and then I have to purchase a mill, and then in a couple of years purchase another mill, but there's a lot of doctors who are really interested in that. What is the best way to start incorporating digital dentures into my practice? I think that the simplest way for most doctors is, if you do not have an intraoral scanner, is to go with the conventional workflow that I referenced earlier, where you're going to make preliminary impressions and have custom trays and wax rims fabricated. When you get those products, you will make your impressions with the custom trays, and you will also put a light amount of wash material in the wax rim, and then start making your marks and records with your wax rim. And you send both of those records back for alignment, and then you'll receive a try-in. And from there, work with my checklists or whatever to evaluate those try-ins, make new bite records, new impressions, whatever you need, and then go to your final. If you have an intraoral scanner, I'm a big fan of going ahead and using the patient's own dentures as your impression tray, as your rim or occlusal device, and as your reference for everything. So I like to use the intraoral scanner to scan those records at that point. The next one is, can you talk more about the process of making partials digitally? So the partials are something that I have not done digitally, and I've only simply scanned the mouth to generate a cast, printed cast, and then went ahead and traditionally fabricated after that. So I can't really talk more about digital partials at this point. How to receive the handouts. So the handouts that I have are my appointment checklists. So they would go into, if you're using the reference denture technique, exactly what supplies you need, what things you need to accomplish during the appointment, what records you need, and it has that checklist. And then I have another checklist for the try-in appointment. I have another checklist for evaluating the digital preview, and those handouts are going to be available on the website. The next question is, how much does it cost to get started? And I don't think it costs anything for a doctor to get started. They would just need to contact their laboratory and find out what manufacturer system their laboratory is using or recommends. If you know of a specific manufacturer system that you would like to use, you can find out from that manufacturer perhaps what are the labs that they work with who have done a lot of cases. So all you have to do is just contact your lab or contact manufacturer and get started with what I would suggest is the custom tray wax rim technique or the reference denture technique. The next question is, do you use the study model mode or the impression tray mode in the trios to scan the dentures? What I do is I make my records and then I use the study model mode and start scanning the entire tissue surface first, and then I start wrapping the scan over the borders along the edges in order to capture the labial surfaces of the teeth. I do have a video it's on Avident's website and also on Facebook that goes over this, but you want to get the tissue surface as well as the lateral sides of the teeth of both maxillary mandibular records, and then you use the trios to align the bite and wait for the trios to go ahead and do the alignment. And that way you'll end up with your maxillary mandibular records, tissue surfaces, and the teeth, and they will be in alignment according to the trios. If you have a single arch, I will sometimes, let's say it's a maxillary denture and a mandibular natural dentition. You can scan the maxillary tissue surface with the trios, scan the lateral surfaces of the teeth in the way that I do it in my video, and then scan the opposing dentition in the mouth, and then scan the two in occlusion. And so you're kind of scanning in the mouth for the opposing and the bite, but then you're also scanning the denture separately in your hand. The next one is, do you scan your denture with the 3-shape intraorally or outside the mouth? And I feel like I just sort of answered that. I do scan the dentures when they're outside of the mouth, but you can, if it's a single arch, scan it within the mouth. I find that when you're trying to scan a dual arch, maxillary and mandibular, that it is easier to just make a bite record and then scan the bite extraorally. And that, because sometimes if the patient moves a little from the right side to the left side, then it's not quite aligned. So I still make a bite record for most of the cases, even when I'm scanning, when I could scan in the mouth. So if I use the patient's own denture as an impression tray, what is the process with the denture while the patient is waiting? I would say that it takes about 3 to 4 minutes to scan a denture with the impression material in it. So my normal workflow is I make the maxillary denture impression first, hand it to my assistant while she is doing the scan. Then I make the mandibular impression, hand it to her, and within about 3 minutes, we're making a bite record, hand it to her, and within another 3 minutes, we're done. And we are removing the impression material. If you use a little adhesive, then well, I definitely recommend adhesive for this, but you need to just use a little alcohol gauze to remove the adhesive from the patient's dentures. So it really is not that long at all to scan with a intraoral scanner when you're doing this.